Hi and welcome to Chapter 4, Positioning for the Hand. We are going to talk about three main positions in the hand: the PA, the PA oblique, and the lateral. If you are requested to do a special view for the hand, you will most likely be doing the ball catchers, or you may be doing a study for foreign bodies, and this will include laterals for the flexion and extension of the hand. When we are doing a radiograph of the hand, we're going to set the patient at the end of the table. You're going to ask them to pronate their hand and spread their fingers slightly. You do the same thing for the oblique. You're just going to adjust the hand to form a 45-degree angle with the image receptor. You can use a 45-degree sponge and rest those fingers directly on the sponge. Central ray for both the PA and oblique is the third MCP. When you are taking a lateral of the hand, you will place your ulna side down. Your elbow will be flexed at a 90-degree angle. The fan of your fingers is created by asking them to make an OK sign or to spread their fingers out. You can show them, and usually it's easier for them to mimic what you are doing than to try to explain it. Central ray should be directed to the second MCP, and in all three you should demonstrate an inch of the distal forearm so that your radius and ulna are both demonstrated on the film. Here's an example of your PA hand. You'll see your central ray right through that third knuckle, which is your third MCP, or metacarpal phalangeal joint. This is a 10x12 cassette, but again, if you're using digital, you can use the 14x17 and collimate down to the area of the hand. Make sure that you have an inch that's being demonstrated of your radius and ulna, and that none of your fingers are being clipped. You then put down the appropriate marker on your film. So again, 10x12, pronate your hand, central ray to the third MCP, 40-inch SID markers, and collimate down. You'll use a half apron for shielding. You will use approximately 60 kVp at 2.5 mass, but in a digital system you could be using 55 at 1.5. It uses less of a technique. When you're looking at the final image, you should see all of the phalanges, you should see all of the carpals, and you should have an inch of the radius and ulna. You are demonstrating the third MCP in the center of the film. There should be no rotation, and you should have adequate density and a narrow dynamic range, or a short scale of contrast, which is black to white. Oblique position, here you'll see they're using a sponge versus when they are not. Your central ray is through the third MCP. Your digits are not parallel to the image receptor. They are at a 45-degree angle. So in both radiographs, these are correct positions to demonstrate the hand. It just comes down to your preference, or if your patient's shaking and can't hold that position, it may be in their best interest to use the sponge. 10x12 cassette, 40-inch SID. You're going to use a little bit higher PA technique than your PA, so probably 60 at about 3 mass. Rotate the hand in a 45-degree angle, keeping those digits so that they're semi-parallel to the image receptor. You're going to center at the third MCP, and your SID should be 40 inches. So again, you want to try your best to keep them at a 45-degree angle, not parallel to your image receptor. The entire hand and carpals demonstrated on your film. Centered to your third MCP, you are coming in through the side here. Your joints will be open, and you'll have adequate spaces so that it's fanned out, and you can actually see the shadow of the sponge right behind here. For your fan lateral, you're going to center to the second metacarpal phalangeal joint. You can see you can use positioning aids to help with this, but most people can hold their position on the side. If not, grab the sponge and put it right up next to the hand. So you can do your hand fan or straight, where you keep the fingers nice and straight. Both are a lateral medial. Straight hand positions, or they're also called true laterals, are done for foreign objects. So if they're looking for a piece of glass in the patient, they will do a true lateral. Fan laterals are best at demonstrating fractures. 10 by 12 DR, you're going to use the 14 by 17. You do want to go up to about 60 kVp at 5 mass, so you're going to use a higher technique. Central ray to the second MCP, 40-inch SID. You use a half apron across their lap. And again, the hand true lateral, spread the fingers. And then for the fan lateral, the true lateral, keep the fingers nice and straight. So it's kind of like a karate chop. Evaluation criteria, here you'll be able to demonstrate all of those phalanges. So 1 through 5, your metacarpals will be superimposed, carpals superimposed, and your radius and ulna are also superimposed. Here's an example of the true lateral. And so you place them in a true lateral and you extend the fingers back for an extension and your flexion. So you have both an extension and a flexion view that you can do to demonstrate those foreign objects. So your entire hand carpals are demonstrated. And so basically you're getting from the very top, or what we call the tip, the DIP joint, and DIP phalangeals, distal phalangeal joints, all the way down to the radial ulna. AP bilateral hands are done mostly for rheumatoid arthritis. Your patient will look like they're catching a ball, so you're basically putting them into a ball catcher's position, resting against a 45-degree angle. You can use a 10 by 12 or 14 by 17 digital plate. Again, just collimate down to the size of the hand. You're going to abduct the thumb and separate the fingers, and your central ray will be at the level of the 5th MCP between the hands. Technical factors are basically about 60 at 5, so it's pretty similar to what you would use on a hand. Make sure there's no motion, and make sure if they're looking for foreign objects or foreign bodies that you decrease your technique.